She's down there. Christiansen's down there.
Thanks, Bill.
Yeah, they're all in the same.
You want to bring all this? It's going to be on here.
They got my good stuff there. In this case,
They all think.
I just. That's a trick. Sure.
Great. All right, I'd like to call to order the State Employee Benefits Committee for their meeting Monday, September 29th, 2025. I'd like to have Danielle Cross with the statewide benefits office do a roll call of all SCBC members.
Director Brian Maxwell,
Here.
Courtney Hutt. Here. Lieutenant Governor Kyle Gay. Here. Paul Bombach,
Here.
Commissioner Trinidad Navarro.
Here.
Jeff Tajner,
Here.
Karen Peterson.
Here.
Bill Oberly.
Here.
Robert Scaletti.
Here.
Treasurer Colleen Davis. Ashley Tucker.
Present.
Stephen Constantino.
Moving on to agenda item number 2, approval of the September 2nd, 2025 SCBC meeting minutes.
Motion to approve.
Discussion first. Do you need
There's a motion first. Second. Second by Tashner. Discussion on the motion.
Mr. Chairman, the section of the minutes that discusses PRC composition, starting on page 3, is incomplete, factually incorrect, and intentionally misleading. None of the 4 pending RFPs state that the PRC shall consist of SEDC members, serving by virtue of their positions. All 4 RFPs state that the proposal review committee may be comprised of SEDC members. Doesn't say must, doesn't say shall, it says may, and that means may or may not. So all of the references in that section of the minutes, all those references to the RFP language are factually incorrect. The same is true for the references to Title 29, which specifically gives appointees the right to name designees to subcommittees. And but for the unwritten and unsubstantiated advice of our legal counsel, this would not even be a question. The second paragraph of the PRC composition section is completely misleading. It says, quote, "The Legislative Council confirmed that they would not defend their opinion in litigation." Nobody ever said they would. They don't represent the SEDC and stated that in their memorandum. The way this paragraph is written, it suggests that the legislative attorney presented an argument that could not be defended in a court of law. And that's not at all what was said. And if their opinion had been disseminated to committee members, as was requested and denied, you would all know what was actually said. The reference to section 2507 of Title 29, which was used as an excuse to deny committee members access to the legislative attorney's memo, is completely bogus. Section 2507 prohibits state agencies or officers from employing outside legal counsel. At no time was the senior legislative attorney employed by anyone on the SEDC. There was no employment relationship. There was no compensation. So the reference to section 2507 is bogus and irrelevant. Finally, there's no mention in the minutes of my objection to the procedure imposed on us after having been told that we would discuss our options on this subject at the September 2nd meeting and make a decision as to how to proceed, only to learn that the decision had already been made unilaterally by the administration, and all they needed was the rubber stamp of this committee. The way this whole thing was handled is a disgrace, and that fact has not gone unnoticed by the state retirees I represent, some of whom are here today. Mr. Chairman, I might have an amendment to offer later, but I will wait until the discussion is over.
Well,
Yes, thank you, Mr. Chair. I want to reinforce or just support the comments of Senator Peterson. I also want to mention that there is a lack of mention that I muted when I was discussing the motion, and I was addressing it with decorum. I was on topic, and I was muted. That occurred at 1 hour, 3 minutes and 17 seconds into the recording. And then subsequently, as it noted, no, I'm sorry, 104:38. I read the rest of those 4 sentences of the chair prohibited me without reason, merely as the chair. That's a quote from it. Like that included in the minutes. And given that I was not able to fulfill my role as a member at that meeting, being muted, I left the meeting. And I'd like the reason for my departure from that meeting to be into the minutes. Thank you.
All right, so we have a motion and a second. Take a vote on the minutes, or as a result of the discussion, would we like to table the minutes to request the members that would like the minutes corrected to have them corrected and reviewed at the next meeting?
Mr. Chairman, I'm prepared to offer an amendment right now.
I'm not sure, in what format would you like to put the amendment?
Just read a sentence.
You can read the sentence, and then it'll be the will of the committee to approve it or not.
Well, then I will make a motion to delete the entire section on PRC composition and replace it with the following. Over the objections of retiree Karen Peterson and DSTA Representative Paul Baumbach, the committee voted to deny appointees the right to be represented by designees on subcommittees.
May I'm assuming, would you like my sentence to be added to yours, or it's a separate?
Let me do it separately.
Okay.
There's a second.
Outside.
So there's going to be another amendment.
Well,
Two votes.
You would vote on the amendment first,
But then he's going to amend it again, so I'd rather not.
but I think he's doing a separate amendment, so procedurally, you have a main motion, now you have an amendment. You vote on the amendment, then they would go to the second amendment and back to the main.
Okay.
And Mr. Chairman, the reason I offer it this way is because this basically sums up the entirety of that discussion. You know, we objected to it, we went ahead and did it anyway, and the end result was that we don't get designees on the subcommittees. So I kept it as succinct as I could.
I need some guidance. I was not in attendance at the last meeting. Was going to go not voting on the minutes as a result of that. And I'm in a conundrum now whether I can legitimately vote on an amendment to the minutes that I wasn't present.
I think that's your personal choice as to what you'd like to do.
If I can just make a personal statement, I was in the same situation where I was not present on September 2nd. So my intent was to go not voting, and I would do the same on the amendment. Okay, because I was not present at that meeting.
That's where I tend to shake out to from a procedural standpoint, not that I do not support the amendment, which I do.
May I suggest that perhaps if we follow the chair's original leaning of tabling the minutes of this meeting, and maybe encourage those who wish to not go abstaining on a enhanced version of the minutes over the next month to.
Well, I don't think that's good. I'm not sure that changed the situation Jeff and I are.
But I think that, my point is, if you're able to review the audio, then you can review what happened during that point in the meeting, and you may feel comfortable to not go abstaining.
Lieutenant Governor.
I think the motion, I just wanted to clarify, was to delete both paragraphs on page 3 of the PRC composition that Ms. Hartos, Director Hartos presented. And I think the amendment would not include the information related to the advice of council. I think it's important to have, because that the council did give advice, so I don't know if it's appropriate to delete both paragraphs so that there's a information about what our council shared with us.
Mr. Chairman, that's exactly the language that should be deleted because that's the language that's extremely misleading. So I was suggesting that we delete those two paragraphs of the narrative and then insert the language that I suggested. But I'm willing to withdraw the amendment if we want to go back and try to work on language that suits everybody, but is truthful. Because this is not truthful.
I was suggesting that if you want to put forth an amendment to the minutes, that we could, I would be open to that. That way everybody could review them, because I don't think we're going to come to an agreement on the fly here, to be honest with you. And I would suggest we table the minutes, and it's already 10 after 2, and I'm not saying this isn't important, but there is other business that we need to tend to as a committee. And I would suggest that path forward would be to provide corrections. And if there's corrections on the side of the statewide benefits office as they're note taking of the minutes, that could be submitted before our next meeting. And then feedback, if there's feedback in between, it doesn't have to wait until this meeting. That way we have a full interpretation of the minutes.
With that said, then I will withdraw my motion. And then Representative Baumbeck and I can work with the SBO to try to get all of this accurate.
Okay. So I would entertain a motion to table the September 2nd, 2025 SCBC meeting minutes to allow time for corrections to go between SBO and the committee members. So second. Got a motion and a second. Can we have a roll call on the minutes, please, of the motion?
Director Brian Maxwell,
Yes.
Courtney Hutt,
Yes.
Lieutenant Governor Kyle Gay,
Yes.
Paul Bomba,
Yes.
Jeff Kastner,
Yes.
Karen Peterson,
Yes.
Bill Oberly,
Yes.
Robert Scaleni.
Yes.
Did I miss it?
Yeah, this is
Commissioner Trinidad Navarro.
Yes.
Colleen Davis, State Treasurer.
Treasurer Colleen Davis.
Director Maxwell,
Yes, Lieutenant Governor.
lest anyone argue with our procedure, I officially withdraw my motion to approve the minutes.
Okay, thank you. All right, I think we got the motion carried and approved. We'll go to the statewide benefits office director's report. I'll turn it over to Director Hartz.
Thank you, Director Maxwell. So I do have some RFP updates to share. So beginning with the Health Data Warehouse RFP, the intent to submit proposals deadline was September 10th. The SBO received 13 intent to bids. All 13 vendors attended the mandatory pre-proposal meeting. The vendors intending to submit a proposal are as follows: 4C Health Solutions, Aon, Artemis Health, Certalytics, the Delaware Health Information Network, also known as DIN, Health Tech Solutions, Innovator, K3 Innovations, eWell AI, Meritive, i3 Tech, On Point Health Data, and Work Partners. The deadline to submit a proposal for the Health Data Warehouse procurement is Friday, October 10th at 1 p.m. For the Vision RFP, as stated last month, we received 6 intent to bids on this procurement. The bid deadline was Friday, September 19th at 1 p.m., and the SBO received 5 proposals for review and consideration. The following vendors submitted proposals: American Family Life Assurance Company of Columbus, also known as AFLAC, IMED, Highmark Blue Cross Blue Shield, Inc., Metropolitan Life Insurance Company, or MetLife, and VSP Vision Care. Lastly, for the Pharmacy Benefit Management PBM procurement, as we noted last month, we received 12 intent to bids on this procurement. The bid deadline was Friday, September 12th at 1 p.m., and the SBO received 10 proposals for review and consideration. The following vendors submitted proposals: Capital RX, CVS Caremark, Empirix Health, Highmark Blue Cross Blue Shield, Inc., Lucy RX Health Solutions, MedImpact Healthcare Systems, Optum RX, Smith RX, Transparent, and Vivid Clear RX. The committee will receive a more detailed status update on the content of these proposals in today's executive session. As a reminder, for all RFPs, the full list of vendors who are submitting or intending to submit a proposal can be found on the GSS procurement website as it is posted publicly. Any questions?
Any questions, committee members?
Just,
Normally,
out of the 12, on the PBM, the 12 within 10 for bid, so 10 submitted proposals.
Correct.
Who decided not to submit proposals, or were there some intervention on the effort on the part of SBO?
So there were two, so submitting an intent to bid is not the same as submitting a proposal. It allows you access to the NDA, to those confidential materials to submit the proposal. So 12 vendors did originally offer that and state they were intending to submit, but only 10 of the 12 ended up actually submitting a proposal. We do have, it's attachment 1 of the RFP, where we follow up with those vendors to ask if there was a specific reason that they did not submit a proposal. I believe we did not receive a response from one, and I can check with our RFP and procurement manager to see what that second response was from that other vendor. I'm happy to share with the committee once we have that.
I want to thank you. I just want to thank the SCDC and SBO with the RFPs, and I look at the number of proposals and number of vendors interested as being a great achievement. And I think compared to the last cycle, these are greater numbers than I remember seeing. So I just want to say congratulations.
Yes, we certainly received more bidders this time around, and not just for PBM, for Health Data Warehouse, that was a very high number. So again, the proposal deadline hasn't been reached for that. So it, as we saw with Vision and PBM, we may not receive all 13. But we'll update the committee at the October 28th meeting. We should have that final proposal number for you.
Mr. Chairman?
Yep.
I'd like to add to Representative Vombach's questions. I think that our work on the RFP, where we removed several artificial barriers to bidding, I think also resulted in a greater number of bids.
we'll obviously have more discussion when we discuss a little bit more details that SBO has to share with us. All right, so I think anybody else have anything on the director's report? All right, we'll go to financials.
Make a present. And all right, I would change that. I'll be able to speak in a second. All right, Sitzel, you should be able to share your screen.
I can now. Thanks, Stephanie. Second. Good afternoon, SCBC members. Relative to August, as you can see, the total month was about $19 million worse than budget for the month. We'll get into the components in a minute, but most of that is primarily driven by actual weekly invoices claims being higher than expected. Relative to premium contributions, only a slight deficit to budget, about $600,000, modestly across the board, but reasonably in line with budget from a premium contribution revenue. Relative to other revenues, August was a rebate month. You can see that commercial rebates came in at $28.3 million versus $33.2 million expected. So a fairly sizable gap relative to commercial rebates. This was offset by about $2 million to the positive relative to EGWIP rebates. We're currently digging into the commercial rebate side of things right now. We have a couple of questions out to CVS relative to this. We can follow up with the SBO and the SCBC at next month's meeting. But other revenues in total about $3.2 million worse than budget, again, primarily due to the lower than anticipated commercial rebates. From a claim standpoint, fairly consistently, the weekly invoices from the Highmark side and the Aetna side for the month of August were higher than budget. We went back, we did a little digging into the flow of invoices within the fiscal year of the GHIP, noticed that month two within the fiscal year. So historically, August in both 2024 and 2023 tended to be a higher month, whereas we phased out the budget relative to book of business seasonality expectations. So we've modified our forecast going forward, or said another way, we believe that the actual results for the balance of the year will be better than budget, and that the $15.3 million worse than budget in August is just a call it a timing or seasonality thing within the flow of claims. We have monitored September weekly invoices as they've been emerging throughout this month, and we did see call it a return to a lower weekly invoice amount relative to budget. So again, to the point of rephasing the expectations for the balance of the year, right now we're expecting the full year to be still only about $6 million worse than budget, or which is ultimately a rounding error in terms of total budget. So we do expect the claim experience to get better throughout the fiscal year, at least relative to budget. And then expenses were only about $300,000 better than budget, but reasonably in line. So again, the whole month, roughly $18.8 million worse than budget, primarily due to the weekly invoice amounts and the commercial rebates. From a long-term projection standpoint, recall right now we continue to present results assuming the 3-year phasing approach that was used to set the 4.2% rate action for FY26, or said differently, assuming an equal 4.2% rate action in FY27 and FY28, even though you are not locked into that. The 4.2%, even though that was the methodology used for setting the 4.2% approved rate action for FY26, again, it was only a singular year rate action. But if you do follow the 4.24242 approach, that would mean that FY29's currently forecasted rate action would jump up to a little bit north of 15%. And then lastly, from a GLP-1 standpoint, recall last month we saw a dip in GLP-1 utilization in July, primarily we believe due to the fact that the CVS formulary change was made effective July 1st, removing Zepbound from the formulary, replacing it exclusively with Wegovy, and there being call it a transitionary period from people flipping over from Zepbound to Wegovy, plus potentially people having more than a 30-day supply. You can see that August shot back up 6% higher than July, but still not yet at the level that we've been currently forecasting for the full year. So we'll continue to monitor that. And that's really a subset of the total claims experience, regardless to financial results. And as I said a few minutes ago, the claims experience has run a bit higher than what we expected. But from a GLP-1 standpoint, right now, we're running lower than forecast. Again, primarily, we believe due to the fact that the formulary change took place on July 1st. So let me pause there, see if anybody has any questions relative to August results. Mr. Bamba?
Brian, just a quick question. On the
Yeah.
long-term projections, do you
Yeah.
happen to have at your fingertips what that fiscal 29% measured increase was a month ago?
I
I think it was 14.
can get it for you. It was lower, not significantly lower, but it was definitely lower. I was going to say in the 15%-ish range, but I can certainly pull up or pull out the July results and let you
As long
know.
as it's in that ballpark, that sounds great. Thank you.
Yeah. Sure.
I think it was just under 15, but
I think you're right, Director Maxwell. I think it was 14.9 if I remember correctly, but don't quote me.
Correct.
Yeah.
It was 14.9%.
Here we go. Now you can quote me.
Just,
Any other questions?
yeah, for my edification, using July and August as an example, July 186 claims, August 4,386, down considerably from September. How does that relate to the number of individuals that are receiving GLP-1s?
So the exhibit on the GLP-1s has claims, which isn't necessarily unique utilizers, but it's ballpark-wise relatively the same and representative of utilizers. You can see that August utilizers shot up from the 4186 to the 4386. The number itself was over 5,000 in June, which is not shown in the exhibit, which is where you can see the 15% decrease in claimed dollars, and generally the price has not fluctuated that much, so that would be similar to the decrease in utilizers as well.
So the claims are reflective of the number of individuals receiving GLP-1s?
Correct.
Hold on that.
Just another related question. Has the SBO received calls about the change of formulary and sort of encouraging people to move from the one medicine to the other in the past 3 months or whatever this first went into effect?
Director Hardis, so we have received a few calls of members who were just looking for information on the appeal process. So there is an appeal process for members who wish to stay on Zepbound and have a clinical indication to do so. And I believe we have had quite a few members who were granted that appeal. So we did receive a few calls from there. I haven't heard of anything in the last few
You haven't had to
weeks
double
or
your
months.
staff or anything for that?
No, we have not.
Good, thanks.
However,
Yeah, and I don't mean to belabor the point. I brought this up a number of times about the impact to the GHIP in terms of GLP-1 costs. I would hope at some point we could have majority of a meeting dedicated to the GLP-1 situation and have a broader discussion about meaningful ways to try to impact the cost without impacting the health of those that are covered under the plan. Again, I think I've used the term almost unsustainable at this point from my perspective. And I also worry about things like, we've never had a discussion about this, when actives and pre-65s transition off the GHIP, they're no longer eligible for GLP-1s under Medicare. And how do we handle that? And how do we transition these people off of GLP-1s? To the best of my knowledge, there is no transition at this point, or no alternative offered retirees under the current situation. So I'd like to have a broader discussion around GLP-1s, including that topic as well as the cost.
just item number 7, when we talk about strategic framework, I think that would be an opportune time for you to raise that point, but it's something that's on our radar. I shared at the last meeting that, I was in attendance of the National Association of State Budget Officers, where Massachusetts and California both announced that they were looking to move away from offering GLP-1s for the weight loss component, but maintaining it for diabetes prevention. So there is this wave of coming to the realization that some of these expenses aren't sustainable. And so obviously there'll be a lot more that you'll hear about with regards to that. Lieutenant Governor.
Thank you. And just about, because I think this is the second or third time Mr. Oakley has mentioned it, and just to make sure you're heard, I think what I know or what I've learned since joining the committee is that things are very much regimented and built out, and that you all have things you need us to accomplish every month. So if we look at the schedule, if we committee address it with number 7, if there are more things to address, we should be honest with each other as a committee that we may need some extra time. And so we should be thinking about what you can fit in, because I know your schedules are very regimented for us.
And if I might add, when the SCBC a couple years ago voted to provide GLP-1s to the GHIP members, that was based on a cost estimate of $2 million a year, if I recall correctly. And I probably would have voted at that time to include that coverage as well, based on that knowledge. So, we've got ourselves in a predicament, and again, from my perspective, it's unsustainable. We really need to have some hard discussion.
I don't disagree with you. I think some of it could come down to plan design as well. As far as plans that we offer to better get at some of these decisions that people are making, from a health perspective. So obviously that I think falls under category, agenda item number 7, which, we're anxiously looking to get there, and hopefully we do get there, quicker.
And Mr. Obley, I know you asked a question about some of the historical stuff, so I pulled up some of the data. The June 2025, so the last month of fiscal 25, the number of prescriptions was 5,443, which gets at the point that it was a lot higher at the end of fiscal 25 than the beginning of fiscal 26, where it dropped down to 4186 again, we believe because of the formulary change. But then you can see month over month, August increased by 6%, which was relatively in line with the month over month increase. And to your point about the total dollars, you're spot on. When the SCBC approved the GLP-1 for weight loss back at the beginning of FY24, the CVS estimate was around 2 million, but actuals came in at 14, and then FY25 came in at 54 million. And now you can see we're projecting FY26 at more than 130 million.
So Brian, also, I just want to remind the committee, UD left the plan, at the end of June as well. So there could be some impact, as far as their departure. So Commissioner, you had a
Just real
comment?
quick, it's just math. So if the number's around 5,000 and June, it looks to be around 11,000. Remember, we think it's gonna double again? I mean, I'm sorry, Brian, go ahead.
Yeah, sorry, Commissioner Navarro. I wasn't sure. Was that question directed at me?
Yes, and the other question is, I'll give you 2. Is that less the rebates, or is this? That's
This
what I'm
is-
trying to understand.
Yeah, this is gross before rebates. And we can't get explicit rebate information on this particular group of drugs, but you're right, it is gross before rebates. And rebates are expected to increase due to the formulary change, partially due to the fact that Wegovy is more expensive on a retail basis than Zepbound. So it came with a higher price tag and therefore an expected higher rebate even on a common percentage basis. But then the negotiated rebates relative to Wegovy were increased due to the formulary change. But you're right, it is gross before rebates. And relative to your question on whether or not we believe it's going to double again, recall that when we set the trend guidance, or the SCVC approved the trend for FY26 and forward. And just let me pull up that deck if you give me a second, so I can show you some of the historical run rates that we were seeing through June. Bear with me for 1 minute. We actually had while the document's opening up, we had a couple of different iterative assumptions that we were proposing relative to the GLP-1 future growth expectations. And while we were reviewing the trend assumption at the time over the few months leading into setting of trend for FY26, the month over month increases in GLP-1 spend continued to be very, very high on a monthly basis, which is where we ultimately landed at the current expectations that the expected gross cost will more than double going from FY25 to FY26. Now, again, part of that's exacerbated by the fact that, again, we're talking about gross cost before rebates, and the gross cost itself of Wegovy is significantly higher than the gross cost of Zepbound, and the utilization was around roughly 50-50 from a Zepbound Wegovy standpoint. But you can see that in FY25, we were continuing to see very high, in many months, double-digit increases, again, month over month in utilization and therefore growth spend, dating all the way back outside of the couple of negatives, the -3 and the -4, you can see month over month trends of 16, 15, 10, 17, 4, 6, 8, which is where we ultimately landed on the overall average monthly expectation of a 7% increase. And recall, we had this big 23% expectation in July, just simply due to the unit cost difference between Wegovy and Zepbound, where while that transpired, utilization dipped in the month. But this is where the expectations relative to the more than doubling in gross spend in FY26 came from.
So I know
Commissioner?
we're gonna go back to 7 at some point, but I think I heard you say Wegovy was more expensive than Zepbound.
It's more expensive on a gross basis, less expensive on a net basis, meaning the rebate differential is greater than the gross cost differential. But again, here we're only reflecting or projecting and showing gross spend.
So are rebates captured under other revenue?
That's right. The rebates are captured up here in other revenues. That's where the rebate side of the equation comes from. And the GLP-1 rebates are buried in these gross total expectations of rebates for the commercial plan.
If it's not too much trouble in the future, could you isolate those rebates so we know what they are?
Don't believe we are allowed to per CVS.
Here we go with the new PDM contract.
We have any other questions? Good. We're moving on to the next item.
Thank you. Good afternoon, SCBC. So we're on GLP-1s. What we have here is a high-level slide of GLP-1 utilization for fiscal year 2025. On the left side here, we see GLP-1 utilization for anti-obesity or weight loss medications. So medications like Wegovy, Zepbound, and Saxenda. The unmanaged costs on that column on the left here were $83.3 million. So all that means is costs before any type of discounts or rebates or prior authorizations were applied. So managed costs, so the blue column on the right there, came to about $27.5 million for fiscal year 2025 for weight loss GLP-1s. So those are the costs after prior authorizations were applied and any cost avoidance that was gained there, any discounts and rebates. So that gets to some of your question there on the overall net costs, including rebates and discounts and everything else to the plan. Any questions or comments on the anti-obesity GLP-1 utilization before I go to diabetes?
Mr. Chairman,
Karen Peterson.
does all of that come back to the state, or does the PBM?
It does. I would I would put it as just the rebate comes back to the state. The rest, the prior authorization, that's more a cost avoidance thing. So it wouldn't be any dollars going back and forth. And the same thing with the discounts that are applied to kind of the sticker price of the medication. So just the rebate would come back to the state.
And the state gets 100% of the rebate?
Yes. Okay.
Jeff Passion.
Jeff Passion here. I just have a question. You mentioned three things: prior authorization, discounts, rebates. Those are the only three factors that are involved here in dropping the cost from 83.3 to 27.5. Is that what I'm hearing you say?
All that I'm aware of, yes.
And are you able to tell us like how much of the drop is attributable to prior auth? How much is discounts? How much is rebates? Or is that something we're also not allowed to know because of CVS?
I think we'll get into that in the executive session, where it's broken out. Sure. Okay. On the right side here, we have diabetes GLP-1 utilization. So thinking medications like Ozempic, Mounjaro, and Trulicity. The unmanaged costs there were $49.3 million for fiscal year 2025. After all that same management is applied, so discounts, rebates, prior authorization, we get down to a net cost to the plan of $10.6 million for the fiscal year 2025. And again, we'll get into more granular view of this in the executive session, but this is kind of a high level overview. Any additional questions or comments there?
Any other committee members have questions? All right, thank you for that.
Sure.
Moving forward to number 5. All right, we'll go to number 5, agenda item, Lantern Surgeons of Excellence Program Incentive Structure.
Great, thank you.
Yeah.
Good afternoon. So we'll take a look at the Lantern Surgeons of Excellence program and the incentive structure, as well as review Lantern's recommendations and then next steps. The Lantern Surgery Care Benefit is a comprehensive program that provides the GHIP non-Medicare, Aetna, and Highmark members access to covered benefits through a network of credentialed surgeons and facilities for planned non-emergent procedures. By using the Lantern Surgery Benefit, members do not pay a copay, deductible, or coinsurance for any services received through Lantern. Members may also be eligible for a financial incentive and travel benefits. With the exception of bariatric procedures, utilization of Lantern is voluntary. Financial incentives are offered in order to drive utilization to the Lantern benefit. On the right, you can see the 4 different tiers of incentives, as well as the procedures that go along with each of those tiers. Next slide. So the SBO requested that Lantern review the current incentive structure and recommend updates based on their book of business. And based on Lantern's book of business, the incentives vary across clients and by procedure, but generally range from $500 to $1,000 per category, with higher amounts for select procedures such as joint and spine, averaging around $2,000. Given the state's rich medical plan design, higher reward amounts have traditionally been leveraged to successfully incent members to use Lantern for their non-emergent procedures. Lantern indicated that data does not yet exist regarding reducing rewards more broadly. However, reducing select categories by conservative amounts for the state should be a low-risk exercise, given the tenure of the program, commitment to ongoing communication, and positive experience with Lantern by GHIP members. If the SCBC were to consider making adjustments to the incentives, Lantern recommends that they be conservative, focus on high volume, high savings procedure categories, and with the goal to limit impact to procedure volume, which could impact the overall savings. So Lantern provided recommendations to make incentive adjustments to 4 categories or 4 procedure categories. So the first impacting joint and spine would be a reduction by 25% from the current per procedure $4,000 to $3,000 for joint and spine. And next, to align gynecologic procedure rewards to the current Tier C design of $1,000. The current gynecologic incentive is $2,000 and in Tier B. And lastly, to increase cardiac procedure rewards to align with joint and spine, which would hopefully encourage greater utilization of Lantern for the high impact cardiac surgeries. So the current cardiac incentive is $2,000 and Lantern is recommending an increase to $3,000. In terms of the expected cost, based on FY25 utilization, the incentive changes above would result in a savings of approximately $199,000 annually. So changes in incentive amounts could change Lantern utilization, whether that's an increase or decrease. And so it's challenging to quantify the actual cost impact that might result from changing the incentives, which could change behavior in terms of utilization. So this table shows the current procedure rewards on the top. Right under that, the proposed procedure awards, the 4 areas I reviewed highlighted in pink. And then below, the adjusted procedure incentives and the reduction in the total spend on incentives. In terms of next steps, the SCBC could consider revisions to the Lantern incentive structure for either a 1/1/26 or 7/1/26 effective date. Are there any questions?
Quick question on slide 6. We have the number of procedures that actually went through the rewards procedure, like the Lantern, but like, do we have numbers as to how many procedures happen in the entire plan by category like this? Because I'm trying to figure out utilization. I know this program's been established, and so that's why you provide, richer rewards. I guess I'm just trying to figure out what utilization is going Lantern as a percentage of the whole.
Percentage of the whole for the GHIP?
That's correct, yes.
I'm not certain about that. I think that's something we can take back and get back to you.
Yeah, Brian, if I could add, Jeff Pashner here. I think it would be interesting to then compare the unit cost. So what's the unit cost under Lantern compared to the unit cost for a similar procedure under the GHIP?
Right.
To see what the difference is. And, the assumption is that, or the understanding was that this would be higher quality care, that the quality metrics were higher. I think I remember you may remember this, like the post-surgical infection rate was less than 1% in their facilities compared to like 12 to 14% in other facilities, and then also lower cost. So, it would be, I think we're at a point where if we have enough data, being able to look at that and see if the hypothesis that led us, or the assumptions that led us this, are proving out to be true in reality would be helpful. Because if they are, I think then we consider, is there also not just adjustment of the incentive cost, but is there potential further expansion of this program to provide higher quality care at lower cost, which I think is in all of our interests. So I would just like to expand on what you've talked about.
I'm sorry, did you have an answer?
Yes, if I may, thank you. Director Hardis, so that's a wonderful point, and we actually did conduct that analysis last year. We do have that material, it's confidential, I'm happy to circulate that again to the SEDC, the results of the full analysis. It was a very intensive and time-consuming analysis. As you know, Lantern has a $1 cost bundled payment, whereas if you go through the health plan, there are many charges over many visits. So developing that and doing that analysis was a much larger lift than I think our office anticipated. However, we do have those results. And as this is a relatively new committee, we're happy to redistribute. And if you would like to discuss that, we can absolutely set that up in another executive session. A very small portion of that, specific to these procedures, will be presented today in executive session.
Yeah, and your analysis will provide data on outcomes as well?
So-
Because I know when we went through the Surgery Plus discussion, that was a big factor in for the services they provide, that the outcomes were better. I want to make sure that we're providing a product here that has better outcomes than what the GHIP participant would get at a local hospital, say, for the same procedure.
So we can go back and take a look at that. My understanding of the analysis was more financial in nature as opposed to clinical outcomes, as we often do not receive clinical data in our healthcare claims database. It's specifically financial. But I'm sure we can work with Lantern to get those results for the previous fiscal year or two if that's
What
requested.
we're really talking about here is the difference between bundled care and fee for service, right?
Correct. Yes.
At the end of the day, and that's something that I hope to address as we go into the TPA
Right.
RFP. So, I mean, I'm not opposed to continuing with Lantern, but I'd like to see us reform the current situation we have generally with the GHIP as it relates to providers and how they're compensated. Bundled care versus fee for service. Okay, I mean, does Lantern use any local providers in their network?
Yes, there are many local Lantern providers. Again, they have to be credentialed as a surgeon of excellence. And there are certain criteria that a surgeon needs to meet to have that level of credential. The number of procedures performed per year, outcomes, to your point. There's a full list actually that's on our website, which I'm happy to pull and share with the committee on what makes you credentialed to be a surgeon of excellence. And there is a pretty wide and growing network in the state. Of course, it varies by procedure. So if it's a procedure that's very particular and not often utilized, someone may have to travel a bit farther, whether that's to Philadelphia to get that procedure. However, we do offer and cover travel incentives, which would include tolls, gas, and hotel stays if needed, if there's not anyone in the immediate vicinity.
I appreciate it. I suspect we may be paying less for a bundled care procedure than we're currently paying perhaps the same provider on fee for service.
It varies by procedure, I would say, but for the most part, that was the intention of the program, and can definitely share those results for all of the procedures. Yeah.
Thank you.
Paul Bombach.
I'm gonna lead with my ignorance. I look at this and say, we're making it harder for women. They were picking out the gynecological and we're bringing it from a $2,000 to $1,000 incentive. It's all of 22,000, or it's like a rounding error impact here. But without knowing what the savings to the plan is, what the cost to the patient is, I don't know how to assess whether that's reasonable or not. But just with what I see here, I'm like, wouldn't want to vote for that. So can you help me with that?
Yes, the savings for those specific procedures and the net cost to the state with incentives and administrative fees and without will be shared during executive session for these procedures specifically.
Are we being asked to vote on this before executive session?
No,
Okay,
no. So
fine.
there were two proposed effective dates. It could be as early as January 1st or July 1st. And we typically like to propose plan changes aligned with the start of a plan year. As this is a non-Medicare specific benefit, the recommendation would be more July 1st. So this is a first preliminary discussion. We have until February to make a decision on any plan design changes.
Thank you.
Lieutenant Governor and then the Commissioner and back to Karen Peterson.
I'll save my question for executive session.
Okay,
Thank you.
Commissioner.
Just a quick one. Do the employees receive, is this considered income? Do they receive a 1099?
Yes, that is a great question. If they receive an incentive over $600, yes, that is considered income and they are required to report it on their taxes.
Can we make that clear to our?
Yes, that is very clear to the member.
Karen Peterson.
Yeah, Mr. Chairman, I believe my ignorance as well. I'm not sure what Lantern is. Is it a group of providers that we're gonna ask people to go to and then somebody's going to get a check in the mail or something? Can you just kind of give me the big picture of what this is?
Sure, absolutely. So the Lantern benefit, it's not new to the state. It was recently rebranded. It was called Surgery Plus, so that name might be more familiar to you.
Yes.
But this benefit, I believe, has been offered since 2020. We're in our second contract with Lantern, previously Surgery Plus, for this benefit. And the goal is to drive care to the center of excellence through the Lantern benefit, as opposed to using your Highmark or Aetna for certain procedures. Of course, as Caitlin had mentioned, our benefits compared to those maybe in the private sector who have this relationship with Lantern, we have very, very low copays and deductibles, so there's not much of an incentive off the gate for people to utilize the Lantern network as opposed to Highmark or Aetna. So there are certain procedures. So for example, bariatric surgery has been completely carved out, which means if you are getting bariatric surgery, you cannot use your Highmark because it's not covered under Highmark. You're required to go through the Lantern program. There have been a few options for joint and spine procedures to also be carved out. The committee had not had interest when that was previously reviewed. That doesn't mean that, of course, we cannot change that as we're discussing future plan design changes. But really the crux of this benefit is members get better care, have better outcomes. There is savings to the state as it is a bundled rate for the procedure as opposed to fee for service with multiple lines of billing over multiple visits and follow-ups and consultations. And the member receives a financial incentive in most instances to utilize a Lantern provider. They're also assigned a care advocate who helps them through that entire process, including to the insurance commissioner's point regarding taxes and information. All of that is shared through the care advocate. And it's meant to be just a better process for elective surgeries for members that results in better outcomes as well as savings to the state.
And so it's Lantern that provides the monetary incentive.
It is through Lantern, however, the state pays it, similar to how we do with our normal invoices for our TPAs and through other healthcare.
So after you pay that, have we still saved any money?
That is a wonderful question, and that resulted in the savings analysis that we conducted last year with the SEBC. There is still a savings. The incentive and administrative fees do eat away at that savings quite a bit, which is why this was proposed today to maybe try to retain some of that savings again by reducing or changing, because in one case, the cardiac incentive would be going up to bring some of that savings back to the state. Yes. And again, a little more detail will be shared on what those price differentials are in executive session.
Thank you.
Commissioner.
Does the employee have the right to refuse the incentive?
That's a good question. I could look into that. I'm sure they can. They have to receive it on a debit card, a reloadable debit card. And before the incentive is loaded, the Lantern Care Advocate will call the member, ensure they have the correct card with the correct numbers before that incentive is loaded. So should the member not wish to do so, they could choose to not confirm their card to not receive an incentive. But if the question is, going right into it, if they could just completely decline it, I'll have to get back to you on that, but I would assume the answer is yes, because again, the employee has to verify their card before the money is loaded onto it.
And if they lose their card? It happens.
It does. Let me follow up with you on that as well.
Yeah, thank you, sorry.
Absolutely.
Does anybody have any other questions on the Lantern surgeon production program? Seeing none, I'd like to skip over agenda item number 6 and go to agenda item number 7. For the interest of the public that's here, I'd rather save executive session to the end. That way people are not waiting around to see what I don't intend to do any official committee business once we go into executive session. And to go to item number 7.
Ready?
Yep, sure.
Fine, thanks for having me. I haven't met most folks, so I'll just introduce myself briefly. I joined State of Delaware account a few months ago, so this is my first time actually formally presenting. My name's Hope Mannion. I'm a senior director at WTW out of Philadelphia. I'm an actuary by training. I've got, gosh, it's come up on 26 years now of employee benefits consulting experience. And one of my favorite things to do in my career is talk about healthcare benefit strategy. So I raised my hand to help facilitate these discussions as we get into GHIP strategic framework. Okay. Well, that's our disclaimer. So what we intend to cover during today's conversation is just a high-level overview of the GHIP framework that's in place today. Kind of talk about how it came to be, SBO and SCBC's role in developing that framework, what it's used for and its value. Going to start with a list of some long-term planning opportunities, some of which have already been raised today. So that's great. You're already thinking about strategy. And then we'll talk about next steps about kind of where we go from here. So just a high-level overview of the strategic framework. It's adopted to outline GHIP goals and guiding principles. In its current manifestation, it's really 4 pieces: a mission statement, a set of goals, and then within each of those goals, there are strategies and then tactics which support the strategy, okay? The mission statement has remained unchanged since it was adopted in December 2016. The goals, strategies, and tactics were updated in 2023 to underpin the 2024 and 2025 strategic framework. So that's kind of come to conclusion. So it's time to think about 2026 and looking ahead to 2029. You can see that mission statement in the box on the upper right-hand side. It says, the mission of GHIP is to offer State of Delaware employees, retirees, and their dependents adequate access to high-quality health care that produces good health outcomes at an affordable cost, promote healthy lifestyles, and help them be engaged consumers. Each one of the phrases in purple font in that box is spelled out in more detail on a slide in the appendix if you're interested in kind of understanding what was intended by that wording. You can flip back there later. And the framework is really important. It provides to SBO the guiding principles by which they're managing the program. So this includes evaluation of the coverages and designs against innovations in the employer-sponsored healthcare benefit space. It helps SBO measure program goals against established benchmarks and develop thoughtful RFPs and recommendations that encourage progress towards agreed upon priorities. So it really does inform almost every activity of SBO, so that's why it's so critical. Questions on that? One more quick comment. I'm about to go over the 4 goals that are in the 2024-2025 framework. They're not set in stone, right? So could be different going forward. Keep that in mind as we talk. And I'll kind of talk to you a little bit about how and why you might want to think about updating, refining, making these your own over the next few months, okay? Okay, so the first goal is driving utilization and alternative payment models. So this strategy goal has already come up a little bit in the room today. This is about getting our participants to types of providers that are delivering care in new ways and really specifically kind of flipping risk maybe back on providers. For example, a bundled fee instead of continuing to pay for bad health outcomes down the road, things like that. The strategic framework has relied upon the alternative payment model framework and fiscal 2023 medical spend as a baseline. That alternative payment model framework outlines a couple different categories of alternative payment models. Could be bundled solutions, could just, accountable care organizations or patient-centered medical homes, things like that. So it's a pretty dense document, but it's kind of the starting point for these. So the goal in the GHIP framework as of today is to really increase utilization of APMs in certain categories. And so how, working with TPAs, other vendors, as well as patient provider education to try to increase utilization in some of those categories. Another comment about these goals is they do have a tendency to weave into each other a little bit. So you're going to see like, and one tactic or strategy may actually check the boxes for a couple different goals. So they're not all just distinct. As a result, for goal number 2, you can see under strategies that it'll say, in addition to those noted in goal 1, right? So we're still keeping all that, like let's try to optimize opportunities to access alternative payment models in mind, but then let's also focus on reducing costs for target conditions. So this is a very common health benefits management strategy, reviewing your spend, figuring out where things are costing more money than others, and then let's try to target those areas through a couple different means. So for 2024 and 2025, the conditions under focus were diabetes, behavioral health, musculoskeletal. So another point as we embark on the development of a new framework is, are those still the right conditions? If you do choose to focus on conditions, which I think should, what are the conditions, right? So we'll at some point be taking a look at utilization experience and just confirming these are still the top 3, or have they changed in the interim? Off the top of my head, just consulting with a lot of different organizations, these are very commonly the top 3 in any organization spend. So not surprised to see them listed there.
Thank you. I like seeing goals. And what I'm hearing is we've got these goals and these are 3-year-old goals, so we need to update the goals. But what I'm not seeing is, and we measured them for fiscal 24, we measured them for fiscal 25, and here's how we're doing. Is that coming?
Yes, next month in October,
Very
we'll
good.
be able to present that information to you.
Very good, thank you.
Okay.
Otherwise, I was going to be festering. So thank you.
No, just you can sleep well knowing that soon you will have all the data you could ever want.
And I
And
think
probably
just to
more.
add, maybe we wanted to make sure that the full committee now is up to date. So kind of getting that refresher since some committee members were new or not in some of the meetings where this was discussed previously.
Go over being the glass half empty guy at the table. We've been having these discussions for over a decade about moving to APM. So this is more than just a 3-year window. And quite honestly, I think the resolution of that question is going to come through the TPA RFP.
I mean, integral part. Yep.
I mean, quite honestly, after being involved in this discussion for probably 2 decades, I think it's the only way it's going to get resolved. Quite honestly.
It is hard to move the needle on these things.
Absolutely.
Do not feel like, lack of progress and saving
The
dollars.
last time I looked at the numbers, it's been a year.
Yeah.
Highmark has fallen down on the job in terms of APM. Aetna's been a little bit better, but not much better. So I don't think they're going to go there willingly, quite honestly. Editorializing.
I could editorialize for hours with you on
I'm
this.
sure you
I'm
will.
not going to. Okay. Any other questions on 2? Again, this is another goal that was already raised today and absolutely should have been, which is targeting high cost, low value care, right? We don't want our participants going to get unnecessary care. We don't want them going to get care from providers who are outsized in terms of cost and or outsized in terms of poor health outcomes long term, right? So how do you get your participants to the best doctors for their medical episode at hand, where they're getting the highest quality care, or I'm not gonna say the lowest price, but the optimal price available in the market. It's very, as you all know, I'm sure just living in it, the US healthcare system is really complicated and very hard to navigate. It's hard to figure out how much things cost. It's hard to really understand the quality of one provider or another. You have a maybe have a COE strategy where we're trying to direct utilization to certain facilities, but within those facilities, providers are all individuals, right? Half of doctors graduated in the bottom half of their class. So how do you get your people to the best provider in that COE facility? So these are the kinds of strategies and tactics that underpin this one. And finally, participant engagement. Again, just another chronic issue in these things is having the participants understand the benefits, understand what's available, understand how to use them, understand what plan option is best for them, given their situation, where they are, and the type of care they're typically going to get. Helping them access providers, helping them behave in consumeristic ways, engage in wellness activities, which, you know, long-term also helps our spend as well. So strategies and tactics along these lines are found in Goal 4. Yeah, that was 2024, 2025. Many of those ideas may still be relevant and valuable. You may want to preserve them going forward. I will say, you know, generally in our work, we are meeting with clients about once a year, about right around this time, to talk about what's new, right? Because your needs may have changed. We'll look at utilization patterns. We'll look to see where people are getting care and what they're getting care for, and that'll help us direct our focus. But there also may be new things, new tactics to consider now. It didn't exist the last time this was talked about, right? So good time, you know, we at WTW will kind of bring that information to kind of help guide you in figuring out how you may want to update these. So we have organized an initial list of long-term planning opportunities for the next framework. These represents the strategies and tactics that support the goals. As I already mentioned, sometimes these things are like a Venn diagram. Like you may have, you know, I think Lantern, for example, like checks a couple different boxes, right? You're getting people to high quality care. It's also an alternative payment method, right? So, and we're going to obtain your interest and feedback through the development process of the 2026 strategic framework. And here's a list that we put together just to give you a flavor for the types of things that we're going to share more information with you about, things you'll be educated about. So again, already raised today, expanding the role of COE partners like Lantern and or considering additional site of care strategies, right? So let's review how Lantern's been performing and think about if you want to expand that model with Lantern, or do you want to, is there maybe another vendor that can help out on those goals alongside? Evaluate member care navigation and cost transparency vendors. So these would be, you may have heard of things like Accolade, where it can be an overlay of benefits and provider system navigation that kind of sits on top of the entire benefits program. And when participants have a question or they have a complicated medical episode, they can call in, they have a coach, walks them through what their benefits are, helps them identify the best doctors and providers for their needs at that time. Another thing I'm excited about in this space too is cost transparency vendors. You may be aware that there was, you know, federal level action in recent years to compel health carriers to publish their cost data, right, in these machine readable files. And it's been a number of years. I think there's been some foot dragging in compliance. They don't really want to share it. The files are hard to download, hard to interpret. They're all different. You know, I recently sat through a training session about how to use AI to actually be able to read these files and things. But meanwhile, there's been this whole ecosystem of startups, data, like health data engineers who are getting, you know, pulling down this data, cleaning it up, making it into tools that providers can use when they're negotiating, and we can use to also empower our participants to have the best costs and value data available. So it's been frustratingly slow, that process, but the market is starting to develop some valuable ideas to consider in the next few years. Enhanced GLP utilization management. I mean, it's a no-brainer. They'll, as already requested, we should be talking more about this, and there's a lot to say. There's, you know, different strategies. You can put together a couple different tactics to try to manage your GLP spend, and every employer in the nation right now has got this in the top item on their list for the upcoming year. So we'll also share with you just different ideas. You know, you can work with your PBM, you can work with, there's different funding ways you can do GLP-1. So we'll just try to give you the full picture so that you can be informed as you think about how you might want to start to manage those. We should be comparing the price comparisons of our hospitals and facilities to other states via benchmark. WTW generally helps with that. We have a lot of benchmarking data, so we'll be bringing some of that to bear for these conversations. Consider implementing a high deductible health plan with an HSA. These are growing in popularity, even with people, not just employers, because of the tax advantage of an HSA savings account. The GHIP does not currently have this option, so something to think about. We can be looking at alternative plan designs or network strategies via the medical carrier RFP, which is what I called it here, but I think I've heard to refer to as the TPA, RFP too, right? So a lot of these goals are going to be part of how we develop that RFP and score it and, make some decisions there. We'll learn a lot about what all the different carriers can provide. Again, there's been some innovations probably since the last time you thought about it. Let's take a look at those conditions of focus and make sure they're still the right ones. We may want to add a new one or things like that. An idea that I'm not sure, actually, I think I meant to delete it after we talked last week, but direct contracting pharmaceutical manufacturers for certain drugs is an idea that's, again, driven by GLP-1s, of course, but it's coming into the private sector a little bit more where large employers are like, help me with this cost and trying to cut deals with the manufacturers directly. So we'll bring a lot of different ideas and we'll just try to quickly shoot down the ones that are just not even practical or feasible for your programs and cull them down into something that kind of makes sense and use that as the basis for the ongoing framework. The process for that. See any questions? Okay. Process for that will be ongoing from here. So in October, we're going to review the results as just raised. So we'll be bringing that data and we'll start to think about the process of how we're going to, what we'd like to do is really facilitate discussion and get all the members' feedback and interest so that WTW can tailor a set of recommendations, updates to the goals that meet your interests, and then, have you iterate with us to refine them from there over probably well into the winter, I'm going to guess from here. So we'll be showing you some data, kind of getting started in October, more to come November and December. And I think that is all I'm going to say about that for today.
Any questions from committee members? Commissioner?
Thank you, Mr. Chair. Couple things. I think the SBO does a wonderful job with sending out the emails and the letters. But I hear this from my own HR department is that we can't get people to respond. They won't open the mail. They won't click on the email site. We'd love to hear your ideas on how to engage the GHIP because I think that's critically important. And what we did in Delaware for the commercial market was this Office of Value-Based Healthcare Delivery.
Yep.
You're speaking our language, not my language, but Christine Vogel's language, where we talked about, we put $60 million back into primary care. So we know it was successful. We talk about things about per member per month, AF payments, things of that nature that I think does work. So when we have that discussion, if it's okay with the committee, I'd love to have Christine Vogel come in and at least join that discussion because she's done this. And we found in the commercial market, again, that's the ACA and not what we do, or not Medicare or Medicaid. It certainly does work, and she is the expert.
She's very good.
Okay.
And the engagement part, I don't know how, the first part of that was, I don't know how. Yeah.
Yeah. Not sure how to answer that. I mean, employee benefits engagement and communication is a whole other thing that WTW does and charges our clients for, right? I mean, we can do communications campaigns, marketing, branding. There's a lot of tricks to try to get people who aren't at their desks to be engaging in communications from HR and whatnot. So it's a big topic. I feel like short term, maybe what we could do is just, our team bring here are kind of the latest big in broad strokes strategies in terms of patient and employee engagement and benefits programs. Are they using a benefits portal? Are they using a concierge navigation vendor, which is frankly very expensive? I think it kind of depends on what people are not responding to. That's probably relevant in thinking about how to tackle the non-response. As far as ongoing problem of employees just really not understanding their benefits, and plan sponsors and employers putting in enhancements to try to get at one condition or another, or to support employees in certain situations, and the employees just don't even know they exist, right? So one thing I've seen of late is you can arrange your benefits portal landing page where somebody goes to say, like, I just learned I have diabetes. Click here, right? And then it will sequence them through like the programs that GHIP is offering for the benefits that they have, to make sure that they're kind of accessing all of the diabetes related support, including mental health care too, right? Because it's pretty distressing to get diagnosed like that, in the order that the state has desired. The state has designed strategically when putting together plan options and benefits, or, you know, could be just found out I'm pregnant, or, you know, just found out, or I'm having a lot of back pain. Okay, well, click here and we can show you orthopedic care via Lantern. We can show you virtual physical therapy versus that vendor, and, you know, just kind of get employees to the content that's relevant to their need more quickly than just kind of reading through their benefits brochure. So, you know, a lot of it is kind of online activity, websites, trying to get people to engage and click through.
Go over the end.
Sorry.
Does that.
I'm sorry, I'm
Go
trying
ahead.
to maintain.
Continuing.
Just did.
Go ahead, if you have.
No, go ahead.
You know, the other one.
I'm less likely to forget.
You know.
Oh, well, I'm catching up. I'm catching up. Look, I'm catching up with you in that area, let me tell you.
We tried any number of things throughout the years to try to drive participants to cheaper freestanding facilities for labs and.
Yep.
And away from emergency rooms versus, you know,
Yep.
urgent care with increased copay, with mixed results.
Mhm.
And it's kind of baffled me, quite honestly. You know, it's one thing that I would consider if I were an active employee today, but the one thing that kind of caught my eye here was understand hospital facility price comparisons to Delaware and other states. One of the things you may want to look at, I think strategically, Christiana Care made a big mistake when they bought Union Hospital, because under Maryland law, their pricing is transparent.
Oh, interesting.
Yeah, and quite honestly, if you look at their pricing versus Christiana Care, what you can discern their pricing is, it's a monumental difference.
Interesting.
So, you know, you may want to start there with the Union
Mhm.
Hospital.
Okay.
But I'm not quite sure how you get to the bottom of all this, in terms of educating participants that there are cheaper alternatives out there. I go to a freestanding facility for an MRI. It's about 40% less than what it would be at a hospital. And I'm on Medicare, so I'm not even dinging the GHIP, really. But how we get people into that mindset, I think, is critical. That, you know, you can go here and pay, you know, $2,000 for this, or you can go here and pay $900. And, you know, in terms of getting them to buy in and have a some fiduciary stake or responsibility in the GHIP, I think is critical moving forward. How you do that, I'm not sure, but, you know, I wish I could get every participant in a room, in an auditorium, and explain to them, you know, that they have a stake in this, because quite honestly, if we don't make changes, you're gonna see a depreciation probably in benefits.
That's right.
Down the road.
It's gonna have to come out of plan design down the road.
So,
Yep.
anyway,
I-
my two cents. But
One theme I've observed over my career is we have been conditioned to assign quality to price level. And very often when we're looking at a list of prices and we're talking about medical care, I don't want the cheapest knee replacement or the cheapest MRI. I'm going to pick something in the middle.
Yeah.
And it's just, I don't know how to get, it's part of how we're conditioned, you know, in a capitalist society. I've also had, one time I had a client that was a union, and they had retirees, and we were trying to put them on an egg whip because the plan was going to save money and the retirees were going to save money. And they just wouldn't do it and they wouldn't do it. And finally, one of the retirees sent us a letter that said, we know it's cheaper, we don't care. We want the coverage we earned while we were working.
Yep.
So it's just like, sometimes it's, they just, people just really struggle
The
with
other
these things.
key to this may be getting to the primary care providers. I'm sorry.
And with let them go, he's on a roll.
We'll schedule another whole session down there.
Yeah, and maybe we can defer that, but
Yeah.
the primary care doctor is the one that sets everything in motion, whether it be a lower price provider or a higher price provider. Once you're locked into that higher price provider, you're in the system.
Jeff Tashner, and then I see Treasurer Davis has a hand raised. And Jeff.
I'll get to the point I wanted to make second, but Billy started with the pricing. So there are 15 examples that we've been given over the last 10 to 15 years about how our market is out of line with similar comparable regional markets. The RAND study data, there was a Hopkins study, all that. So I'm going to be really interested just telling you up front when we talk about benchmarks, because one thing we've had over the years about benchmarks, and I'm not suggesting you would do this, but it's consultants coming in here and using the surveys of their clients, which is always a very, when you ask, well, we sent it out to 140 and we got 20 responses, and none of them are the same type of plan. They're small private employers. So please, let's really dig in on that, because the most frustrating thing being at this table from now the second go around is we've always talked about how we're going to come up with the money to pay more, but we've never talked about how we're going to get the prices in line.
Exactly.
And even I looked at it when you said it, our definition is part of the problem, because we start talking about tracking the trend. If your prices are 40 or 50% above where they should be, and you just track the trend, they continue to be 40 or 50% above where they should be. So I'm just warning you ahead of time. There's some people at this table that have been waiting for this moment for a long time. It's gonna take a while to get through. I want to talk about the insurance commissioner. I think part of the problem is we got to look at the relationship that we have with the plan members and the time when we ask them to make decisions about healthcare. And it's usually when they're filling out all the paperwork, right, for employment, and they just fill it out. When do you go back and really engage in a conversation? And I had this talk with Faith, and I had it with Mike Jackson and other people. I think this is an area where you got to spend more up front to realize benefits in the back end. Because what you're trying to do is make an informed consumer of healthcare. And quite frankly, the online portals, they're great, but they don't create the relationship. And this is about a relationship that, number one, we got to realize most of the plan members don't trust us right now because of what has happened in the last couple of years. So you got to think of a process that builds trust so that they're willing to look at stuff and understand that it's in everybody's best interest. So I'll be interested in that, because I do think it is a real problem, Trini, but it's not one that's going to be easily solved by an email or a portal or some sort of program. I mean, I had a lot of questions about the My Benefits Mentor that we were using, because it was people were going in, but like, what was it really doing to help change their thought process? And I think that's where we have really fallen down. And I'll be interested to hear what you got thoughts on those kinds of solutions. And I, for one, think, again, this may have to pay more upfront to realize savings on the back end. So just put it out there as a marker.
Treasurer Davis?
She's unmuted. Maybe she doesn't know. We can't hear.
We'll go to the Lieutenant Governor.
Just a quick question. This discussion that we're planning, what's the setup of the discussion? Are we gonna be walking around the room with sticky notes? Are we doing facilitated whiteboarding? Are we just talking like we're talking now? Like, it would be good to know how to prepare.
I think we need to figure that out amongst ourselves, like how we want to kind of conduct and sequence. you know, do we want to walk you all through a strategic framework and then kind of have like a workshop, or have you, you know, send thoughts in email? But I think Chris and I are going to collaborate on kind of facilitating that discussion. So we'll share those details maybe in October.
Okay,
Does
thank
that
you.
sound fair? Okay.
And sorry, my second suggestion is just a YouTube series with Director Maxwell to all the employees. They can watch that. Right? We'll get them all really engaged.
That won't be part of the strategic.
I will put on a sticky note. Just in case.
Treasurer, can you speak?
Yeah, thank you so much. I just wanted to echo Jeff Tashner's thoughts there. I will say that I think I'm one of the individuals who's been around this table who's really been kind of interested in making sure that we're thinking about the value of the care that we're providing. And I think you really touched on something that's really important, which is the relationships. I also appreciate the fact that in some of what we're talking about, you know, Willie Towers Watson mentioned the medical home and how important it is, because I think that's a relationship that be better established for state employees. That's the primary care medical home. But one question that I had, and it's actually for Mr. Overly. So Bill, I don't know if you are willing to share.
Always willing to share.
We know. You're breaking up on us, Treasurer, you're breaking up on us.
We don't know what Bill's supposed to share.
Yeah.
Yeah, I was just wondering if Bill is willing to share why he chooses different areas of level of care for his MRI location.
Why
Why do you choose a standalone?
One over the other.
because I'm keenly aware of the price difference and the outcomes are the same.
Good, Treasurer?
Yeah, so it's helpful, right, to just understand what that process is like for you. Bill, is that because you pay the difference, or you're just a conscientious consumer?
No, I feel a responsibility to look for the vendor that's going to suit my medical needs at the lesser cost, you know, with the same quality and same outcome. I mean, it's just, perhaps it was the way I was raised. I mean, born in the 40s, you know, back in the 50s, nobody had a lot to go around, so you tended to be more frugal and discerning in how you spent your money. So just a natural outcome for me.
Okay, and again, Bill, it's not your money that you're spending per se. You're just a more informed consumer.
Agreed. I don't know what else I could say. I mean, why would I?
Okay.
Why it would be irresponsible from my perspective to go pay 40% more for the same thing if I could get it at a cheaper cost at a freestanding facility. And if you could get everybody, the GHIP, into that mindset, you know, would help to lessen the financial burden on the GHIP.
But that's because of what you've learned through these meetings over the
Yeah, I
years.
mean-
That's really the key, is that
Yep.
by being at the table, Billy and I have had this conversation probably more times than we'd like to admit. You know, you look at, it's a stunning, significant difference between the standalone facility and hospital-based. I mean, when you look at some of the tests, it can be the difference of several thousands of dollars. And it's just because
Yeah, in
of
some
what
cases,
we,
magnitude.
yeah, I mean, what we've learned here that says to us, why are we gonna put the plan through that? Because if we can contribute to the plan saving money, because we're getting good quality at a different facility, lower cost, that's what we're gonna do. The challenge is, how do you get all the plan members to the spot we've gotten Billy Overly to over the course of the past couple of years? If we can do that, it's definitely gonna drive down the overall cost of the plan.
All right, I know we're running.
Yeah, I think that's the point I'm trying to make. So thank you.
So I think we're running a little tight on time. Obviously, I gather there's a lot of energy around, moving forward with a framework. So in the next couple agendas, you'll see this item pop up. So when everybody engaged, if we want to start and take a crack at what our mission statement is, because I understand some people feel it probably needs to be tweaked a little bit. So maybe that's where we start. But also the results is a part that Paul mentioned. So we'll start with the results, talk about mission statement, and then start building off of that. And to the commissioners, suggesting having that person maybe come and participate and talk about some of the other things that we've done, that would be helpful. Does everybody go with that?
Thank you.
Anything else? No? Okay, I would like to, if there's no objection, go to public comment in the interest of the committee. We'll be going into executive session. I do not plan to carry in other committee business once we exit executive session, so I'd open it up for public comment.
Nobody's present, such as in public comments. Steve L. LePage. Yes, can you share your screen?
I have something I'd like to say.
Okay. Hold on 1 second.
I'm sorry.
Did she ask for?
Yeah, I did. Could you just state your name and then?
Yeah, okay. Hi, I'm Rebecca Scarborough, retiree, 20-some years ago. I've been an observer of the SABC for over 10 years. When most of you were not on it. I mean, 1, 2 of you probably were. And I missed the 2 years during the pandemic when things changed drastically and we went to Medicare Advantage. I'm a member of the Delaware Retired School Personnel Association. Your work is so important and so hard. And one of the things I'm concerned about a great deal is what's happening at the national level. And I don't know how you're going to address all of that. I'm just happy to be in a blue state, I'll tell you that. But when you talk about the differentials between hospital and standalone, I was doing that until my doctors moved to the hospitals. I've lost 2 of my doctors who now are affiliated with the hospitals, and I have no choice but to go where they want. And I've had 2 surgeries within the last 2 years, and was told that it would be better for me to get my x-rays and my MRIs and my PET scans and everything I needed for my surgeries through the hospital facilities. So I think you need to be aware of that and what's happening to our primary care doctors. I was a patient of Dr. Sweeney's. Now he's with Bay Health. And then I'm downstate, so I have downstate stroke doctors just moving on to BB. But I just wanted you to be aware of that. I think a lot of us try to save the money, but sometimes we don't have the choice. And some of it has to do with the transfer of data, because my surgeon, whom I've had to operate on me twice within the last 2 years, said that the information he gets from the hospital tests were more accurate than what I might get and were easily translatable than what I might get from a standalone. Just wanted to add that.
If I might respond.
Usually I don't respond to public comments, but that's your
Just a little guidance. I've run into the same situation. I've had 2 Christiana care specialists that almost demanded that I have tests done within the hospital. I refused, went to the freestanding facility and brought a disc to them.
Yeah, I've done that too.
So it's almost as if it's self-perpetuating, if you will, in some of these hospitals that they do.
Yeah.
Mr. Chairman.
Mayor Peterson.
Something to it, what Bill just said. Also, I've heard of cases, especially downstate, where the doctors get into the hospital. And these are doctors, in one case where the guy went every month to get an injection in his knee. And all of a sudden, not only is there a copay, but now he has a hospital fee added to it of $125. So, you know, those things need to be watched as well. I have faith dealt with some of those issues for me.
Director, there's another in person.
Another person, other comment?
Lee Disco, I'm a retiree.
I can't hear you.
Lee Disco, I'm a retiree. I just, and I was a nurse. But my question is, at one point, I always thought that there was a difference in the type of equipment the hospital has compared to a private other company, that the hospital equipment was better. And that was an explanation I was giving for not going to the smaller.
Yeah, they all say that.
But my question is, do we know whether it is or not? And how do you find out?
They're all regulated, so the equipment is the same.
Anyone else?
I'm sorry, Mr. Oberly, that's not true. The resolution on different imaging studies is different. And it's not entirely true that they're all the same across the board. And so I would just say that I would be cautious with making that statement.
That was the state treasurer.
Anybody else in person? Steve LePage. Mr. LePage, you should be able to unmute your microphone.
Yes, can you hear me?
Yeah.
Okay, great. Thank you. As many of you know, I've studied hospitals and I've studied prescription drugs and things like that. I've been studying that since around 2014, I would say, when Colin Benini was the state senator at the time, because I had emailed him several times on these issues. But as far as the hospital costs are concerned, I just sent you guys another email one that I had sent to you previously in April, and it concerns the cost comparison between Christiana Care in Delaware and Union Hospital in Maryland, which is, if it's Newark, I think it's 12 miles away, and if it's Wilmington, it's 20 miles away. So just to give you an idea of some of the differences in costs, Keytruda, for instance, is $7,000 in Union, and it's $23,000 in Wilmington. Opdivo is $9,300 in Union, and it's $30,000 in Wilmington. Evaluation costs of, for instance, a PT for low complexity is $241. In Wilmington, it's $483. Just medicines alone as well. Union for Metropol, $275 a pill, $1475 a pill in Wilmington. So these drugs and these procedures are a lot more, about 3 or 4 times more than our neighbor 12 miles away.
Timer is up.
You can submit your comments in writing if you would like to share them.
Yeah, I forwarded that email to you guys already.
Thank you. Anybody else for public comment? Seeing none, I would like to entertain a motion to enter into executive session.
Second.
Motion and a second. All those in favor say aye.
Aye.
Opposed?
Aye.
Seeing none, executive session. Break the allow people to.
No, I didn't.
June to vote is just what's going there. So we could just.
Yeah, she has the.
Motion to adjourn. Second, all those approved?
Just sentiments.
Yeah.
Yep, appreciate it. Thank you.
That is an amazing facility.
It is. It was the,
Thank you, everyone.
absolutely the right thing to do.
Sound good stuff.
Thank you, Thursday.
She had said for years because of.
It's, I think it's great, if you focus and know what I mean, you know, you have someone there, we can actually give you. We're just trying to keep it to where you know, you just like. Motion advice. Next one, I think that's October 3rd.
Well, I
said,
I can bring you a dinner.
Come tomorrow. Yeah, okay. Thank you, guys. Have a great night. Good to see you. I need another coffee for the ride.
I